So we'll Perfect. Thank you so much.
Mhm.
So, good morning, everyone. I'm just going to go ahead and we'll get started. It's my pleasure to introduce Dr. Amanda Keller-Ross this morning, giving a talk about her research. She will be serving as one of our faculty mentors for this new Pathways program. So we're really excited to have her join us today. So please give her your full attention and engagement this morning. And Manda, I'll go ahead and pass it on over to you. Thank you so much.
Yeah, absolutely. Good morning, everybody. It's a pleasure to be here. I'm super excited to be a part of this program. So thank you, Liz and Jessica, for organizing this and inviting me to be a part of it. So I'm going to talk a little bit about, I'm loving the cat, Devin, in the background, just crawling all over your equipment. It's pretty funny. Um, I have a dog that tries to attack me when I'm home giving presentations, which is why I did not do it at home. So, um, I am going to talk a little bit about some research that I'm really passionate about, and I have two arms of my research, and I feel a couple of you are going to hear this as a repeat from Friday as I talked about some of this. But one of the arms is women's health research, and that's what I'm going to speak mostly about today. And that is something that I feel like I kind of developed from the bottom up, which has been really neat. And I'm hoping that at some point before I die, we'll be able to figure out some pieces of why women are dying of cardiovascular disease earlier and earlier, and how age and menopause are influencing some of this risk. So that's what I'm going to give the talk on today. I think the paper that you read is on some of the neuromodulation work that I also do. And so I have this arm of my research that's really targeted towards, what types of neuromodulatory techniques. And when I say neuromodulatory, I'm speaking about different devices that we can use to essentially interrupt the process of our nerves or modulate our nervous system in some way. And so I think the one that you read was transcranial direct stimulation. And so we've done some studies looking at that and how that influences autonomics. And I'll talk about autonomics today. So if that word scares you, don't worry, we'll get into it. And then also we do some work with vagus nerve stimulation, which is the parasympathetic system of the autonomic nervous system, and then some spinal cord stimulation. So there's all different ways we can modulate nerves in the body. And this is a way of looking at non-pharmaceuticals to regulate blood pressure and try to decrease hypertension and cardiovascular disease risk. So I'm gonna start giving my presentation, and when I present, I'm sure as most of you, if you've presented on Zoom, you can't really see anybody, but I really do want to encourage you to keep this as interactive as possible and just come off mute and ask me a question. I can't see hands, so Liz and Jessica, if one of you can interrupt me at any point in time. It's easier to do that than to try to hold on to your question. And so if I don't know the answers to your questions, I will try to find out for you at some point. So let's see if I can.
I did just have a super quick question.
Yeah,
Some of your research, particularly into women, and just expanding the knowledge in that field, we kind of talked about last Friday.
yeah.
It's just sort of how that's been neglected. Do you ever do research around infertility rates and how they're increasing?
No, that is not an area of my research, although I don't know if I know anyone in my field that's actually doing that. But what I would say is that it is it's another one of those like missed opportunities, and something that it could be increasing or something that we just haven't looked into, so it looks like it's increasing. And I often wonder that with cardiovascular disease risk, if that risk was always there, or we're just now paying attention, so now the risk is increasing. Do you know what I'm saying? And so I just think that there's probably a lot of unknowns in regards to that. And I don't have a good answer for you because that's not part of what I do, but really, really good question, and a lot of good inquiry can go into that.
Yeah, thank you.
You're welcome. All right, let's see if I can. Get some of these controls out of the way. And everyone can see the screen okay?
Yeah, looks great.
All right. Okay, so I'm going to talk about how age and menopause influence blood pressure regulation in females. And I use females intentionally because we're really trying to identify sex differences. And so in the field of science, most previously, I would say we've used the word gender. And gender is a social construct where sex is looking at biological differences. And so occasionally I may say women, but really what I'm looking at in my studies are sex differences. Now, that doesn't mean we ignore the social constructs of gender identities at this point, but we have lots of different questionnaires where we try to get at some of those answers, and some of that data is just not incorporated into this presentation. All right, so here's a bit of an outline of what we're going to talk about today. I'm going to, and hopefully I don't have to work too hard at it, expressing the importance of understanding cardiovascular disease in women's health. And then we're going to back up a little bit and talk about the sex and age influence on blood pressure regulation. I'm going to speak specifically about autonomics and a little bit about vascular blood pressure regulation. And then we'll get into some factors that need to be considered when thinking about menopause and cardiovascular disease. And this is where I'll get into some of the research that we're doing, where we're curious about the age of menopause, so when menopause is completed, and then how sex hormones play a role in the cardiovascular disease risk. And then we're going to talk about symptomology, and symptomology is something, it's kind of becoming a buzzword. We're talking a lot about hot flashes, which are vasomotor symptoms, night sweats. These are some of the primary and first symptoms that women or females will experience when they go through menopause. We also do some work on sleep difficulty, and some of that I'm not going to talk about today just for time, but I'm happy to discuss, later on after the presentation or another time. Okay, so cardiovascular disease is the leading cause of death in females, which is pretty well known at this point. But I think what's more alarming is that about 56% of females are aware of this. And if you ask a lot of females what they think it is, and it's they'll say breast cancer, which breast cancer is definitely a huge scare. And something that women need to be concerned about in the sense of at a certain age, making sure you're getting your mammograms. But it is not the leading cause of death in females. So 1 in 3.2 deaths in females each year is caused by cardiovascular disease. And there are sex differences in the presentation, outcomes, and the mechanisms, making cardiovascular disease a more severe disease for females than males. And so a couple of examples of this is that 64% of females versus 50% of males who die suddenly of coronary heart disease will have no previous symptoms. And more females than males die within 1 year and within 5 years after their first myocardial infarction, which is also called a heart attack. This is a figure from a bunch of data from the National Center for Health and Statistics that looked at how the percent of population who develop hypertension changes throughout age and between men and women or males and females. So if you look at the x-axis, we have age that's grouped here. And then on the y-axis, it's the percent of population who have developed hypertension. And then in blue are the men and the red are the women. And so one thing that you'll notice in these younger age groups, men have higher prevalence of hypertension, but then something happens right around this age group, and then women will surpass that of men. And so if I could pause here and just ask, what do you think is happening right around this time frame that maybe we should pay a little bit more attention to?
Menopause.
Menopause, exactly. Thanks, Colton. So what is menopause, right? So menopause is the cessation of sex hormone production from the ovaries. And this can happen a number of different ways. The most typical is the gonadal aging. So your ovaries essentially stop producing estradiol or estrogen. So just so I don't mix up my terms here for you, estrogen is the more common way we describe the sex hormone, but there are 4 different types of estrogens in the body, and estradiol is the most bioavailable for females in their reproductive years. So if you hear me say estradiol, that is why.
Dr. Ross,
Yes.
I was going to ask on that previous slide, how are you defining hypertension? Like, is there a certain blood pressure number that you get to?
Yeah, that's a great question. For some reason I'm blurry here. Do I look blurry? A little bit. I was gonna try to fix that, but I won't. So the definition of hypertension has actually changed throughout the last, I would say, 20 to 30 years. And the most recent uh, guidelines for diagnosing hypertension is 140 over, I'm sorry, 130 over 80. So any blood pressures that are above 130 over 80 are considered hypertension. Now, if we go back and look at the states, this is 2010. So this is likely when blood pressure hypertension was diagnosed with a 140 over 80. So the guidelines have consistently come down in the past few years.
And then how do they rule out transient hypertension? Does it to be diagnosed and included in some of these studies, does it have to be a consistent reading for so many visits or?
Yeah, so generally what'll happen, you go to your primary physician and they check your blood pressure. And I think one thing that's really important to acknowledge is they're trying to change the way blood pressure is taken at clinics, right? Because you're rushing in, you get there, they take your blood pressure and your blood pressure is elevated because you're at the doctor's office and all of these things, right? And so now what they're trying to do is have people just sit in the room 5 minutes, 10 minutes, and get some really good resting blood pressures. And then what happens, let's say you have an elevated blood pressure, your physician will generally have a conversation with you and say, these are the things that might be contributing. We know that diet influences blood pressure. We know that exercise influences blood pressure. And so they'll send them away with these guidelines, eat healthier. We become more salt sensitive as we get older. So as we get older, they'll say, have less salt in your diet, exercise more, all of these things. You come back in 3 months, they check it again. If you are still hypertensive at that point, they may consider putting you on some sort of diuretic. That's generally the first drug. And then you will likely get a diagnosis of hypertension at that point.
Okay.
And so then they'll continue to monitor that. And it's not that once you have hypertension, you always have hypertension, right? You are able to, in most cases, you can control it with diet and exercise, but there are certainly genetic factors. There's lots of different factors that play a role. And one thing I'll just note here as you're asking this question, Jessica, is blood pressure regulation in the body is multifactorial, which is awesome in the sense that if, one of the factors, for some reason something happens to it, like you have a lesion somewhere or it stops working, we have all of these other mechanisms in our body to help regulate blood pressure, right? It's also really challenging when it comes to studying it because you're studying, like for me, I'm studying 2 aspects that control blood pressure. And then there are 3 or 4 other ones that also help to regulate blood pressure, right? So we have all of these different factors, and you'll kind of see that as we're talking about what contributes to blood pressure regulation.
Thank you.
So transient hypertension is just fluctuating between in and out of that guideline range.
Correct. It's a short term, like a short spike in blood pressure.
Got it.
Okay. So I think we were at premature ovarian failure. So this is when your ovaries stop producing estradiol at a young age. And so this is usually they'll call it premature ovarian failure when it occurs before 40 years of age. There's also surgical menopause, and so this is a bilateral oophorectomy and a total hysterectomy. There's around 600,000 bilateral oophorectomies a year, which is quite a bit. Half of them are because people are estrogen receptor positive for breast cancer, and so if you remove their ovaries, that will reduce their chances of getting breast cancer and ovarian cancer by 75%, right? So that is really important to do, but then just looking at the potential for the increase in cardiovascular disease risk, just knowing that can help women and females exercise more, or just give them more information and the ability to counteract the risk of cardiovascular disease. The other half is generally elective, and there's different various reasons why females will choose to do that. And then there's medically induced. So certain types of chemotherapies and certain types of drugs can induce menopause. Now, when it's gonadal aging or premature ovarian failure, it's clinically considered menopause when it's 1 year past your final menstrual period. So it's not that you go to the doctor at a certain age and they start testing your estradiol levels or your progesterone levels or your FSH, which we'll talk about in a little bit. It is, when was the last time you had your period? That's what they will say. And then once you have 2 missed periods, then they consider you perimenopausal. Once you have 12 months without a menstrual cycle, then you are considered in menopause. The typical age that this occurs is around 50. Of course, this is in the US, it's different for different cultures. And there's, of course, an age range for this. Approximately 10% of females will experience menopause, premature or early. And this is defined by the age that menopause happens. And so when I say when menopause happens, I'm particularly talking about when it's completed, not necessarily when you start developing symptoms or start missing your periods. And so approximately 2% of these females will have go through menopause before 40, which is considered premature, and around 7 to 10% will be between 40 and 45. And so what does that mean? It means that many women will spend 40% or more of their lives in the postmenopausal phase. So mechanisms are certainly not clear, but we do know that the risk of cardiovascular disease increases during and after the menopause transition. Nope, I have a couple extra things there. And so this is a very complicated slide, and I certainly don't want you to look and be overwhelmed by it, but it's really to demonstrate a couple of things. That there are about 10 stages. This is a study from they're called the SWAN. It's the study of women across the nation. And so they have identified essentially 10 different stages throughout life that women go through. And one of the things that's important about this is that in each one of these stages, something could happen that could increase your risk of cardiovascular disease. I want you to really think about them in 3 stages, right? Our reproductive years, and that's when menarche happens, right? And so that's when girls start getting their period. There's research to suggest that that will influence cardiovascular disease risk, right? Pregnancy, so there are things that happen during pregnancy that can increase cardiovascular disease risk. The menopause transition is the next phase I want you to think about, and then there's the postmenopausal phase. I spend most of my time talking today about the postmenopausal phase, but the next research that we're starting to do is really focused on this menopause transition, because now what's happened in our literature is that we have a lot of information about women in this stage of their life and women in this stage, and now we're missing women in their midlife years, right? So we have no idea what's happening during this stage. Okay. Now, there are sex hormones that will differentiate males and females. And so one of the big ones is estradiol, and the other one is testosterone. So both males and females have estradiol and they have testosterone. It's not that, only females have estrogen and only males have testosterone. It's just the amount in which we have. And so this is looking at the variations in estradiol fluctuations around the final menstrual period. So 0 here is the final menstrual periods. And so these are the years leading up to the final menstrual period. And then this would be considered postmenopausal phase. And so again, this is from that big multi-site study, the SWAN study. And if you just keep your eye on the red line here, this is what a lot of people associate with menopause, is that as you get closer to menopause, you just start to have this decline in estradiol, right? And then all of a sudden, they're just at really low levels. And it's not that it goes away, because our fat cells also produce estradiol. So even though our ovaries may not be producing it, our fat cells will produce it. So there's always a little bit of estradiol in our body. But what this study found was that's actually not the case, which makes things even more muddy for us to understand, is that some women have these really big spikes in estradiol and then a really sharp decline. And then maybe less of a late and less of a spike and then a sharp decline. Some will just kind of flatline here in the green. And then you have those that have this natural progression, right? And we have no idea if any of these fluctuations also contribute to this risk, right? So is there more associated risk with this sharp decline? And the reason I mention that is because there are a few studies out there that will show that females that go through surgical menopause have even more of a greater risk than women that go through menopause naturally. Now, this is the other side of things that we really don't understand either, and this is the follicle stimulating hormone. So there is a process that happens. It's a cascade event that starts with the hypothalamus, which will produce follicle stimulating hormone, and we also call this FSH. This is a hormone that we study in our lab, but at this point, we know very little about what FSH does in the body. And so FSH will send signals to the ovaries to produce more estrogen. And so when estradiol, so let's say that there's gonadal aging happening and the estrogen is depleted from the ovaries, that will send signals to the brain. It's a negative feedback loop. It'll send signals to the brain to say more estrogen, more estrogen. So more FSH will be secreted from the hypothalamus. And so FSH just keeps going up. But estradiol cannot go up because the ovaries can no longer produce. So we have different levels of FSH that are also being produced. And so there's again, I'll just reiterate, these are really important hormones in our bodies that we have no idea how it's influencing cardiovascular disease risk. Okay, so hopefully you believe me that this is an important area of study and that we know very little about it, right? And so I'm going to take a little bit of a step back, because this difference in blood pressure regulation in males and females starts in the reproductive age, right? And so I'm going to talk a little bit about the autonomic nervous system. Now, there are really 3 aspects of the autonomic nervous system. There's the sympathetics, the parasympathetics, and the enteric, which is the gut. And we're not going to talk about the gut today. We're going to talk about the sympathetic and the parasympathetic. The sympathetic nervous system, there are these sympathetic ganglia. It's a chain that goes down the sides of our spinal cord, and then they send these nerve fibers out to all of our organs. And so one way you can think about this system is our fight or flight. So if you get excited, your sympathetic nervous system is going to activate, your heart rate's going to go up, your blood pressure is going to go up, right? And one really important structure that the sympathetic nervous system innervates are our blood vessels, all right? This is really important in blood pressure regulation. So one of the ways this happens, this is oversimplified, but think about it like this. Sympathetic activity increases. The blood vessels will constrict, they'll squeeze, resistance goes up, and your blood pressure goes up, okay? Now, the parasympathetic nervous system is our vagus nerve. This is a cranial nerve, a nerve that comes from our brain, and it is the longest nerve in the body. And the vagus nerve has many sites of innervation, the heart, the gut, the lungs. And one of the main functions that we think about with parasympathetic nervous system is that it's our rest and digest. So it really aids in the digestive system, but it also relaxes us. The vagus nerve is hot right now. It is a hot topic. Everyone wants to know how to activate the vagus nerve and how to activate the parasympathetic nervous system so that we can be more relaxed. We can relax our system. And so what I want to get across here is that the autonomic nervous system is critical for homeostasis, right? It's important for cardiopulmonary function, intestinal function. The list goes on. This is not an exclusive list, but it is important for all of these things to function. So
I
as
just
you
had
see
a
Yep.
really quick question. So the parasympathetic nerve, is that sort of going to be the difference between a quadriplegic who has no bodily function above the neck and like a waist paralyzed person that still has digestive function?
It's not necessarily all about the vagus nerve because you're going to have a lot of sympathetic innervation all the way up until that lesion area. Does that make sense? And so your the sympathetic activation for blood pressure regulation, all of that's happening in the thoracic cavity. And so it depends on where that innervation is happening to really understand where the loss of that function is.
Yeah, that was a really good explanation. My not to interrupt, but my father had ALS, so it's definitely something I'm interested in and would like to learn more about.
Yeah. Yep, I hear that. I actually just went to a ALS fundraiser this past weekend. So
That's
um
awesome.
yeah, we could talk more later, Colton. So as you can imagine, if there's an imbalance here, it's going to develop into lots of disorders and symptoms, right? And usually what we see is sympathetic activity going up and parasympathetic activity going down, or another way we like to say that is parasympathetic withdrawal. But it results in arrhythmias, cardiovascular disease, chronic inflammation, which is becoming another really hot topic, because we think this inflammatory response is involved in hypertension, cardiovascular, like all of these things, right? But in any one of these disorders, one thing that you're going to see is this imbalance of sympathetic and parasympathetic function. And so my lab is really interested mostly in hypertension and cardiovascular disease. But in saying that, what I want to emphasize is that obesity plays a huge role in this. And renal function plays a huge role. The kidneys are huge in blood pressure regulation. And so it's one of the areas my lab is starting to think about. But again, it just reiterates this idea that this is a multifactorial process and so many of these systems contribute to cardiopulmonary function. Okay. Now, this is a bit of a complicated figure. This was a review article done by Michael Joyner, who is a anesthesiologist and an expert in vascular function down at the Mayo Clinic, and I did my postdoc with him. And so what he did in this review is he tried to identify all of the different sites that there are sex differences in blood pressure regulation. He's stuck with the autonomic control because it could probably be a book if we looked at all of the different systems. And the one major thing I want to point out here is what estrogen's doing, okay, or estradiol in the reproductive years. So estrogen's known as sympathoinhibitory. So if I say sympathoinhibitory, what does that word mean to you? What do you think's happening?
It's going to inhibit, I guess, the effectiveness of the sympathetic nervous system.
Absolutely. Yep. It's going to essentially blunt or depress some of the effects of the sympathetic nervous system, right? And so for women and females, we often say they're cardioprotected in a sense. They have lower blood pressure, they have lower sympathetic activity, right? And so I'm gonna talk a lot about this right here in just a second, but I want to bring your eyes over here to this idea of nitric oxide. Does everybody know what nitric oxide is and what it does?
I do not.
Nitric oxide it's one of our most potent vasodilators. And essentially what that means, if you're looking at the blood vessels right here and you release nitric oxide, blood vessels will go like this and they will dilate. Well, what does that mean? It means that you have more blood flow. It means that resistance goes down and your blood pressure goes down. Estrogen has an effect on the beta adrenergic receptors, which will influence the release of nitric oxide. So for females that are in their reproductive years that have estrogen, they have more ability to vasodilate and lower their blood pressure, right? So now we have lower sympathetic activity, which is going to lower blood pressure. We have greater vasodilation of the blood vessels, which is going to lower blood pressure. So overall, in the younger females, we see lower sympathetic activity, this greater ability to vasodilate, and lower blood pressure. Okay, so all kinds of things happens with age, right? And you know, I was telling the group on Friday, but I'm also a trained physical therapist. So when I was in the clinic and I was talking to one of my patients and I was really expressing the importance of exercise, and I said, you know, exercise is anti-aging, and they said to me, well, if you put that in a pill, I'll take it, right? And so I thought, okay, well, that's essentially what's wrong with the world, is everybody wants a quick fix, right? But that's the truth, is that with age, you get this arterial stiffness, right? So your arteries become more stiff. You get this decreased baroreflex sensitivity, and I know that's a new term at this point likely, and essentially what the baroreflex does is it helps to modulate short-term, it's like a fine tuner of blood pressure, right? So if you are stressed out and your blood pressure goes up, your baroreflex will kick in and it'll bring blood pressure back down. But with age, that kind of goes away a little bit, right? And so your ability to bring blood pressure down decreases. So your heart rate goes down. There are some intrinsic changes within your heart that causes heart rate to go down. In particular, females, you lose estrogen when you go through menopause, right? So you don't have this ability to vasodilate anymore. You also have an increase in sympathetic activity. So these two things are more prominent in females because of the loss of estrogen, although all of this happens with age in both males and females, but it's more prominent in females. So now I want to talk directly about this muscle sympathetic nerve activity. This is the gold standard measure of sympathetic function, and this is the technique that we do in my lab. The technique itself is called microneurography. And so what we do are we take these small little electrodes, they're high impedance tungsten electrodes, and we put them into nerves. Now you can put them into any nerve in the body. We use the one, this is the fibular nerve. It's from the common nerve that goes right behind the leg, and then it splits, and one goes deep, and the other one is more superficial that comes right around the fibular head of the bone right here. And we do this under ultrasound, so we're able to identify the nerve, and then we put the needle into the nerve. Now, this is just a schematic of the different iterations of this nerve and where it splits. In some people, it splits down here, and it's called the common perineal up until it splits. And then it has different names, the deep perineal and then the fibular, because it goes along the fibular bone. Now, inside the nerve, there are different fascicles. There's a muscle fascicle and there's a skin fascicle. And they're both important for autonomic function. But the muscle fascicle in particular gives us really direct measures of what's happening with blood pressure. So if muscle sympathetic nerve activity goes up, blood pressure is going to go up. It has a pretty direct relationship acutely. And we get something like this. We call it a neurogram. Now, one thing, I'm going to oversimplify this for the purposes of the concepts. one way to think about this is that every time you see one of these bursts that kind of look like an action potential, every time you see one of these bursts, I want you to think about the vessels squeezing and pressure going up, okay? Now, these are some images of the work that we're doing in our lab. This is one of our participants. This was like almost at the peak of COVID, so everybody is all geared up. We don't necessarily have to do that anymore. But this is the ultrasound machine here. And then this is my team, Dr. Emma Lee, who's a postdoc in my lab. This is Dr. Nova Tassin. She is a graduate student, but also a physician. And then Miguel Anselmo, who was a graduate student in my lab. So here's another close-up of what this looks like. We do some blood pressure measurements. So we do our measurements here, the manual ones that you generally see at the clinic. That's gold standard. So we do those measurements. And then we have what we call a non-invasive blood pressure cuff. And this is just a little cup that goes on the finger and it squeezes the finger. And we're able to get beat-to-beat changes of blood pressure. And then we do these stressors. One stressor we do is exercise. There's different reasons that we do exercise. I won't get into it today because I'm going to speak mostly about this next technique, which is called the cold pressor test. This is essential. It's an awful test and nobody likes it. It's 2 minutes long. And the reason nobody likes it is because it's pain. If you ever put yourself in an ice bath or done a polar plunge or had ice on you, it's fairly uncomfortable. But one of the things that we use it for is that it causes massive sympathoexcitation. So your sympathetic nerve activity goes up, your blood pressure goes up. And what we know from previous literature is that if you stress the system and you have normal or abnormal responses to stresses, that's a fairly good predictor that you're going to develop hypertension or cardiovascular disease later in life. Now, I say that knowing almost over half the population already has hypertension. So we could just use that as an indicator of who's going to get hypertension. About 50% of us are going to get hypertension, right? But in a young group, and there's these longitudinal studies for over 30 years that will show if they have a hypertensive response to the cold pressor test, which is 2 minutes long in an ice bucket, they will potentially develop hypertension later in life. So we use this test in our lab. And so the first study that I'm going to show you is looking at how age and sex influences blood pressure regulation. And so this table is just demonstrating some of our demographics. And so we have a group of young, a group of older, a group of young men, and a group of older men. And I won't go into too many of the differences here, but I will say if we look at their sympathetic nerve activity, and this is the way that we quantify it, so how many bursts are there a minute? And then we also account for their heart rate because you can only have 1 burst per cardiac cycle. And so you can imagine that if you have a higher heart rate, you have more opportunity for bursts. If you have a lower heart rate, you have less opportunity. So we also just use that as a way to normalize MSNA. And so you'll notice that in both the older groups, sympathetic activity increases, right? That's something that is not novel from this study. This is something that we know. What is different in our study that we saw, and again, our numbers are fairly small here, but one of the things that we saw is that MSNA or sympathetic activity was actually greater in the older males at rest compared with the older females. And there's lots of studies that will show that, or that women will have a greater trajectory of an increase. So it could just be the age of these individuals. It could be the differences in physical activity levels, because we know physical activity will decrease sympathetic activity. But we don't really know the answer to that question in this study. But one of the things that I want to show you is what happened with mean arterial pressure and heart rate and sympathetic activity. Now, one of the things that we hypothesized is that the older women, because of this greater risk, that they would have these elevated blood pressures to the cold pressor test. If you look at this figure on the x-axis, there's baseline, which is rest, and then it's all relative to baseline. This is the time point of the cold pressor test. So this is 30 seconds in. This is the average of the first 30 seconds. This is the average of the next 30 seconds. at the 60-second mark here, and so on. So it goes for 2 minutes. And what we see is that essentially there was no difference. There was no statistical difference here, but the males do have a slightly greater increase in reactivity to the cold pressure test, which was surprising to us. This is not what we expected to see. Heart rates, there was an age effect where heart rates had a less of an increase in the older population. That is fairly expected compared to the younger population. But what was novel from this study is that even though MSNA at rest was greater in the older males, look at this reactivity in the older females to the stressor, right? So within 30 seconds, they had a much more rapid increase in sympathetic activity compared to the older males here in the open squares and the young males and females, right? And so this is whether we were counting for burst incidence or burst heartbeat per heartbeat, 100 heartbeats, or bursts per minute. They have this exaggerated increase. So essentially, what does this mean? So they have this greater MSNA or greater sympathetic activity, but blood pressure was not that different. Well, essentially what it means is that as these women get older, they need more autonomic support of their blood pressure. So for the older men, it was likely that they had other mechanisms that kicked in to help keep their blood pressure up, where for the older women, they really relied on autonomic support or the sympathetic nerve activity. Okay, so I just want to go back to this figure that we've already seen and emphasize what we didn't really look at in this previous study is menopause. Right? So we have no idea if that was age, if it was menopause, what was happening. So that is essentially where a lot of the last 5 years of our work has gone into, is to try to understand the difference between age and menopause. In one sense, you can say, well, can you really tease that out? Because menopause occurs with age in women. And so my answer to that is, in some cases, no. But in other cases, what we might have to do is manipulate the system a little bit. And I'll talk about that in a little bit. But the first thing that we really tried to do is try to separate them out by looking at the age of menopause, right? And so that's what I'm going to start talking about first, is this age of menopause. And there's a lot of research, this is just one study, but there's a lot of research out there to suggest that the age of menopause plays a key role in the risk of cardiovascular disease. So this is the incidence and risk of heart failure and AFib, and we're going to focus on the heart failure aspect. And just as a note, heart failure is your inability to pump out the blood or to fill your heart enough to get enough cardiac output to get blood flow to the tissues, right? So your whole system essentially is compromised because you can't get blood out to them. And so once that happens, we call it heart failure. And this is looking at the age of menopause, and heart failure is at the top here. So this is what we're going to focus on. And then this is again when menopause was completed, so before 40. And then in 50 or above was the reference. So that you'll see that as a 1 here. And now if we look at these different models, model 1 wasn't adjusted. And when I say adjusted, what I mean is there are other confounding factors that influence heart failure. So pre-existing cardiovascular disease will affect it. Your BMI or obesity will influence it. Whether you have diabetes, so alcohol, sleep, like all of these things, right? And so model 2 adjusted for age, smoking, alcohol, activity, and income, and showed that when you adjust for it, there's about 40% increased risk for heart failure if you've gone through menopause before 40, all right? And about 10% if 45 to 49. So even before 50, there's still a bit of a risk. Now, if we adjust for all of the other factors, which are all listed down here, that risk doesn't change all that much. So we know that age of menopause will influence the risk of heart failure. So this is, I would say Dr. Lee and Miguel really lead a lot of these studies in my lab looking at menopause age and blood pressure regulation. And we hypothesized that because of all of these large epidemiology studies that are suggesting this, if we're looking down at the basic level, that we would see earlier menopause would result in elevated blood pressures, measured by our non-invasive B2B blood pressure monitor, elevated sympathetic nerve activity, and a lower forearm vascular conductance. And so this is a way that we measure blood flow. I won't get too far into the technicalities of it, but if we measure blood flow, then we can look at vascular conductance, which is just the opposite of vascular resistance. And so in this study so far, there are 20 women who have gone through menopause before 50, and then 12 that have gone through menopause after 50. So it's really important that they're age matched because we know age influences them. So these are almost directly matched. These women in this group have gone through menopause or completed menopause around 44 versus 52. And so they've been in menopause significantly or essentially double the years that this group has. BMI is the same. This is a measure of their physical activity, essentially the same. And of course, their sex hormones are essentially the same. And so what we found is that although mean arterial pressure looks slightly elevated in the females that went through menopause before 50, it's not significant. It's not even close. And the part of it is that there's a lot of variability here. If we look at MSNA, it's also similar. But one thing that we did find is the vascular conductance was quite a bit lower. And if we look at it the other way and flip it around, resistance was greater in the women that went through menopause, premature or early, suggesting that there's a greater vascular transduction or autonomic support of blood pressure in women that go through menopause before 50. This is looking at it in a slightly different way, where now we're looking at a younger group. And so this is what we would consider, or the NIH, the National Institute of Health, would consider women in their midlife. And so these are women that are 42 years old, and we have a group that's postmenopausal. So now this group has gone through menopause premature or early. And again, the subject numbers are quite low. And one of the reasons they're low is because a lot of women in this group are likely on hormone replacement therapy. And that will essentially lower your blood pressure, lower your sympathetic nerve activity. Lots of studies have demonstrated that. And so in order to be a part of our study, they have to come off. And these women are generally on hormone therapy because of their symptoms, because they have lots of vasomotor symptoms, they can't sleep. And so it's to help control those symptoms. And so they don't want to come off their therapy to be a part of these studies, which is completely understandable. And so there's 14 premenopausal women. So these are the women that have not gone through menopause. And so the only differences that we see here that we would anticipate is that their sex hormones are different, and that's because this group has not gone through menopause yet. And so what we see here in this smaller sample is that mean arterial pressure already in the younger group is starting to creep up here. In the postmenopausal, it's not quite significant yet, but if the number is small, we anticipate that to continue to grow as we collect more data. MSNA, or sympathetic activity, is already very elevated in this group compared to the premenopausal females. Again, the subject number is low, and we'll see what happens as we continue to collect data. But vascular conductance really isn't that much different. We have a huge variability with the women that are postmenopausal. So what might be happening is in the younger group, MSNA, or sympathetic activity, is already starting to elevate. So these women are just in a longer duration of time with high sympathetic activity, leading to elevated blood pressures and hypertension. Okay, we are at 9:50. I just want to check in with Liz and Jessica on time. Do you want me to be done right at 9:50? I can cruise through some.
No, you can take your time.
Okay. All right. Does anyone have any questions? Do you want me to pause and talk about anything that I've talked about already before, or go ahead and keep going?
I
Yeah,
just had, you guys go ahead.
You can go first, I guess.
Okay, I'll go. So I was just curious, did you have any study subjects that were like needing to like go through some sort of procedure that would cause the menopause to happen sooner to see blood pressure before and after? I know there's probably other effects that they needed to do that, so that would probably affect it.
Yeah, so that's a really good question. So what you're asking, I think, let me just make sure I answer your question correctly. Have we been able to look at some of these factors before they go through like a surgical procedure, like a bilateral oophorectomy and a hysterectomy, and then look at it after to see that direct effect? Is that what you're asking?
Yes, yeah.
So there's actually a study going on at the Mayo Clinic right now that's doing that. I don't know if any of you have heard the name Virginia Miller. I think she's going to retire soon, but she's a huge name in this field, and her legacy is really trying to understand this transition with surgical menopause and how that influences blood pressure regulation. And I don't know if we have an answer to that quite yet. I think one of the gray areas is we don't really understand the amount of time it takes for sympathetic activity to start to creep up, right? And for estradiol, that loss of estradiol to start to have its effects, whether it's like acutely, which I can tell you is likely that it's pretty acutely. There's a group down in Denver that, and this is something that we're going to do in our next study, is to put premenopausal women into menopause. And you can do this with a drug. It's a gonadotrophin releasing hormone antagonist. So essentially, you're blocking that system and estradiol levels will just plummet. And within 3 days, they see a huge change in the vascular system. And so it is quite likely that the changes occur very soon. That study just hasn't been completed yet. So I don't have the answers to that. But that's a great question.
So this shows how green I am, but can you go back 2 slides?
Did I go
Yeah,
too?
right there.
Yep.
So I just have a quick question. What do the plus and minus signs represent? Is that just going up by 12 and down by 12?
Oh, that's a great question. Thank you. I should have explained that better. So that is our standard deviation, essentially. So essentially exactly what you described. Was that Ashley? Is that who asked that question?
Yes, it
Somebody-
was Ashley.
Okay, great. Yeah, so essentially if I were to say it a different way, the postmenopausal women were 42 years plus or minus 4 years. So there's a bit of a range, and that's the standard deviation on both sides of that age range that they were. So that essentially shows how variability or how homogeneous or non-homogeneous my group is. Does that
All right,
help,
that
Ashley?
explains it. Yeah, thanks.
And then I was just curious, sort of from all of this data, can we infer maybe that the female body has a greater ability to modulate its autonomic nervous system, or is there just more factors in men that are requiring it to not modulate as much?
So I think that in reference to the first thing that you said, I think it actually might be the opposite, that because in the presence of estradiol, the ability of the autonomic nervous system to modulate blood pressure is actually blunted or less. And then that changes with age, and we rely on our autonomic nervous system more so than we did premenopausal females. In men, it's mostly the effect of age. Now, there is an andropause that, men can go through, which is like a loss of testosterone. And we don't necessarily know a lot about that. But for men and males, testosterone is really important for cardiovascular health. What's interesting is if you give testosterone to females, it has the opposite effect. And it's not cardioprotective. It's actually more detrimental for females. And so there's a lot of studies out there right now in trans individuals to try to understand this influence of sex hormones, particularly when you're giving giving estrogen to a biological assigned male, right? And then all of a sudden they have all of this estrogen. Should that be beneficial to them? Because it's beneficial for females, right? Because they're cardioprotected. And that's not always the case. So there's something about, the system as we age and as we adapt, that when you change the sex hormones or you put, more of one in an individual that, maybe they weren't used to that level of sex hormones, it can be more detrimental. Did I answer your question, Colton, or did I sidetrack?
No, you absolutely answered my question. And I think it was the ice bath data that kind of threw me off, just looking at how that was affected by that test.
Yeah.
But yeah, that was really an awesome answer to my question. And I actually have to log off, but I really appreciate you presenting this slide, and it was so informative.
Yeah, awesome. Yeah, thank you, Colton. Did I get everyone's questions answered? Okay, so this is just the piece on the sex hormones. And one of the things that we have a tendency to do is look at things in isolation. And so people will look at estradiol and does it have, what influence does it have, and what does testosterone have? And so these are some studies essentially that just say we need to start looking at them more. And one of the things that we did is we wanted to understand, well, what about the relationship between the two? We're looking at them in isolation, but what about how does total testosterone to estradiol influence the system? And there are a couple of studies out there that will show that, in the presence of disease, so cardiovascular disease, coronary heart disease, and heart failure, they will have higher levels of total testosterone to estradiol. Now, this study is primarily females, right? This is postmenopausal females. And so the individuals that have a higher total testosterone to estradiol ratio, particularly in cardiovascular disease or heart disease, they will, let me say that again. So on the y-axis is the higher hazard ratio right here. And so this is the total testosterone to estradiol ratio. So the higher you go up on this scale, the more testosterone to the estradiol that you have. And so essentially what this is showing is that the individuals that have cardiovascular disease will have a higher testosterone to estradiol ratio. So what we wanted to see is, does that influence sympathetic activity at all? And so we just took all of our premenopausal females and all of our postmenopausal females, and we put them into this linear regression model and looked at sympathetic activity in a couple of different ways here, and found that if we adjust for age and BMI, which we know those two things will influence testosterone to estradiol ratio and cardiovascular disease, that the presence or the ratio of testosterone to estradiol can explain 11% of the variance in MSNA burst frequency. So it's not everything, right? So it's not all about the sex hormones, but it can influence sympathetic activity regardless of pre or postmenopausal. Okay, so I'm going to switch over to some symptomology. And so it's really important to understand that these symptoms for women, some women don't have any symptoms. That's a pretty small population of the women, though. It's about 20% maybe. But 70 to 80% of females will experience vasomotor symptoms. And again, these are hot flashes, these are night sweats, profuse sweating. And so we don't really understand the relationship, or we don't really understand the mechanisms of why that might be contributing to blood pressure regulation. But there are several large-scale epidemiology studies that will show these really strong relationships between the higher severity, the higher presence of these symptoms, the more risk women are at. So we don't know if this is it mechanistic? Like, is there a direct relationship? Is this some sort of physiological response of the hot flashes? Or is there the psychological component? As you can imagine, you're out in public and you start sweating profusely and have a hot flash. That's not necessarily a pleasant event, right? And so some women will experience 20 to 30 hot flashes a day. Okay, so this is it's not only uncomfortable, but it can influence and is potentially a biomarker for cardiovascular disease. Okay, so I think I actually went ahead of myself and talked about all of this stuff. This is another study from SWAN, the study of women across the nations, that demonstrated if we look at the association between baseline vasomotor symptoms and fatal and non-fatal cardiovascular events. This is women. There's 3,000 women in this group, a little bit more or over 3,000. On the left side here, you see frequency of vasomotor symptoms. So this is 1 to 5 hot flashes per day over a 2-week period. This is greater than 6 a day over a 2-week period. And what they found is if we look at this model 2, which again is adjusted for all of these other risk factors, that there was a 50% increased risk of cardiovascular disease in women that have 6 or more hot flashes a day. Okay, we really don't understand why that is. So Dr. Lee led this review paper a couple of years ago, and we looked at all of the studies out there that were just looking at blood pressure. So like baseline blood pressures, ambulatory blood pressures, when you were asleep, when you were awake, to see, okay, so they have a greater risk of cardiovascular disease. Do they actually show a greater blood pressure? And a good number of the studies did. So if we look at the y-axis, this is the difference in blood pressure as a percentage. And these are all the different studies that were out there that we looked at. If it's above 0, it indicates that the females that had vasomotor symptoms had a greater blood pressure compared to those that did not express symptoms. And so most of the studies did, but not all of the studies showed a greater blood pressure in females that have or express report vasomotor symptoms. So I think that maybe the jury is still out on that. And so Will is a PhD candidate in my lab. And so he's really interested in the physiological response of a hot flash and potentially how a hot flash really could contribute to greater cardiovascular disease. Now, this is a study that was not necessarily focused on vasomotor symptoms, but this was our first look at it. And so we have this group of women, 34 of them reported vasomotor symptoms, 24 of them at the time did not have vasomotor symptoms. All of their demographics are essentially the same. The only thing that's different is their report of vasomotor symptoms. Now, the one thing that the caveat here, although there's a significant difference between the group, 1 means that they did not have symptoms at all. Anything above 1 indicates that they had symptoms, and then they reported them on a scale of how bothersome they were, with 6 being the most bothersome. So moderately bothersome. This is not necessarily a severe group here. And what we found, this is very similar figures to what you saw before, where time is on our x-axis throughout the cold pressor test. Mean arterial pressure, and these are absolute values on our y-axis. VM plus, these are women that in the blue that expressed vasomotor symptoms, and then in the maroon they did not. And we found no differences in blood pressure reactivity, no differences in heart rate reactivity, although there was some of the females in this group had lower heart rates, which we have not been able to understand why yet. And then what we did find is that if we particularly looking at MSNA burst per 100 heartbeats, so this is accounting for the heart rate, that the individuals that had vasomotor symptoms have higher sympathetic activity compared to those that did not. But if we didn't count for heart rate, we did not see that. There's always this debate on which one of these measures are more important. If we're looking strictly at blood pressure, it's likely the burst per minute. So this may not necessarily be a huge effect that we're seeing here. So now what we're doing is we're going to dive a little bit deeper into this. And we want to know what happens during a hot flash. And so for this study, we're actually inducing hot flashes in women. I say flash because that's the normal terminology, but we call it a flush because it's not necessarily a flash. It doesn't happen and go away. It can sometimes stay for 15 to 20 minutes in women. And it causes this flushing experience. So we call it a hot flush. And so for this study, what we're doing is we're monitoring skin temperature and we're monitoring skin conductance, which is a way of monitoring sweating. So think about skin conductance as sweating. And skin conductance is the gold standard measure of a hot flush. And so this is looking at this individual, this is when they said they were having a hot flush. And this is when they said the hot flush ended. And the 2 here means that this was their second hot flush that they had. And then this picture, you're going to see where we put the sensors. So all the sensors are on the neck, because when, in general, when a female will say they're having a hot flush, they'll say it kind of starts around here and then it just rises up and they feel it in their head and the back of their neck. So what happens during a hot flush? And we are inducing them with heat. Just we look at them for an hour spontaneously, and then we just heat them up. The room is like 85, 90 degrees. We've got temperature controlled heating pads on them. They've got warm balloons in their hand. We just heat them up. And what we found in this one individual, this is a study that we're just starting, so we don't have a whole lot of data on this quite yet. But in this one individual, we found this dramatic drop in blood pressure during a little bit before the hot flush. And these dotted lines are actually when the individual said they were having a hot flush. And so likely the hot flush started before, and this is when they were like, oh, yep, it's coming on. So it's a bit of a delayed subjective response here. And so if you think about it, is this reduction in blood pressure really a risk factor for cardiovascular disease? In a sense, wouldn't that be potentially a good thing? And so what we hypothesized was happening is that when this drop in blood pressure is happening, that there's a consequent increase in sympathetic activity to regulate blood pressure. And so when I talked about the baroreflex before, this is essentially what the baroreflex is doing. A drop in blood pressure, the baroreflex is sensing that, sending signals to the brain, get sympathetic activity. You'll see this huge spike in heart rate. That's one thing that women will report over and over again. It feels like my heart is racing when I'm having a hot flush. Well, that's exactly what we saw. Well, this is the other thing that we observed, is that sympathetic activity increases. This is a massive increase in sympathetic function during a hot flush. So one of the things that we're hypothesizing in this study is that women that have more frequent hot flashes are having these sympathetic surges throughout the day, really elevating blood pressure. Okay, so I'm going to summarize. I think I've gone way over, and I apologize for that. Some of the things that we talked about today is sympathetic reactivity to a stressor is greater in older females compared with age-matched males and younger adults. Females who complete menopause before 50 demonstrate lower vascular conductance than females who complete menopause at 50 or older. Premature early menopause may contribute to this greater sympathetic activity independent of the age effect. And females with hot flushes experience a greater autonomic support of blood pressure during stress and an increase in sympathetic activity during hot flushes. So I just want to acknowledge this. It takes a village to get all this work done. This is my lab. Some of the individuals are missing. Lots of collaborations and some important grant funding that helps us to pursue these dreams. So I will stop there. We had a lot of discussion throughout, but I'm happy to take more questions.
Thank you. I'm excited. I want to work in your lab for a little while.
Come on over, Jessica.
All right.
Me too. I want to come.
Hey, who's going to lead the program?
Yeah, they'll be fine. They'll figure it out.
You all can come.
Other questions? And maybe this is a question just in general. Like, my understanding is that for hysterectomy patients, if you do a partial hysterectomy and you leave the ovaries, that you don't see these effects.
That's correct. So
Okay.
if you leave the ovaries, they're still going to be able to produce estrogen. it's not necessarily a downside, but the hard part about that for any research study is they will generally not know when they go through menopause unless they start to have really frequent symptoms. But if they don't have symptoms, they'll have no idea because they obviously will not get their period anymore without a uterus.
Right.
But yeah, this is, as long as they have their ovaries and they have their estrogen, they're generally protected.
Okay. Do they still go through hot flushes?
If so, the hot flushes is again, we don't really necessarily, there's this mechanism in the brain. So it's the thermal regulation system is in the hypothalamus. And for women that experience hot flushes, they have a higher brain norepinephrine. And norepinephrine is our catecholamine for sympathetic activity, but it doesn't translate to high peripheral sympathetic activity. It's only in the brain. And what ends up happening is they have a smaller, like thermoneutral zone. And so if their temperature rises above that zone, it triggers a hot flash, right? And so for some women, this doesn't happen, right? But for some, when they have this estradiol withdrawal, essentially, it'll trigger all of these hot flashes. So it's considered part of the estradiol withdrawal phase of menopause, and also one of the symptoms that kind of goes away as you get older. So a lot of these women won't always have hot flushes. They may have them for a year, they may have them for 10 years. I've also talked to women in their 70s who still have them. So that's the other like muddy part about this, is that there's so much variability in women that it's hard to study.
Yeah.
But not doesn't make it less important. It's just hard.
So hot flashes only occur when temperature rises above that baseline and not like when they get cold.
Correct. It generally will it's generally due to your temperature rising. And so a lot of times if a woman's having a hot flush, you'll see them like go outside. Or you'll see someone take their jacket on and off because as soon as the hot flush is over, they get this shivering response, right? So you've all experienced that shivering response. They'll start to like shiver a little bit. And so that's to help bring their temperature. They shiver to bring their temperature down a little bit, and then their temperature rises again. So they're constantly in this fluctuation of trying to regulate in this very narrow thermal neutral zone.
Got it.
Thank you so much. Any other questions from students? No. Well, we really want to thank you for taking your time and going over your research and allowing some of our students to come in and work on projects. So we really appreciate and value your time.
Yeah, I'm happy to do it. And hopefully I didn't derail your morning too much with going over.
Oh,
But
be fine.
okay, great. Well, thank you all very much. And I look forward to continue working with you.
All right. Thank you.
Thank you.
Bye.
All right, students, we're going to take a
think you're muted.
Thank you. I will start talking about research elements. Hopefully it won't take up too much of your time and give you a little bit more time to read articles for tomorrow's presentation. How did you guys like the presentation, the research?
I thought it was very cool. I think very beneficial, sounds like.
Yeah. It's fun to hear about the research firsthand and as they're doing it. And so I find these research talks very beneficial because they'll show you preliminary data, what they're working on, like that one graph was just one patient because they're just starting it. And so you get to see some of that data before it's even published or worked out. All right. Well, let's talk about research elements. All right. So I have I'm gonna move that out of the way. All right, so we're gonna talk about research elements. The first thing we're gonna do is identify the research elements. We'll do a research process overview, the types of research, and then scientific writing. Some of this is, like a lot of this is preliminary. Most of what I'm trying to give you is some background information so that when you go into the labs, you're kind of aware of these things. All right. Here I'm going to ask for audience participation. In 1 or 2 words, could you describe a research element? So I could use like hypothesis, right? What else do you think?
Control group.
Okay, let's just type right in there.
Also keywords.
Control group. Keywords. I'm terrible at spelling. All right. What else do you guys?
Safety first.
Safety first.
Precision.
Precision.
Accuracy, maybe. Both. We'll say both.
That is definitely not spelled right. Precision, well. Okay, and that precision and accuracy kind of go with data collection, right? Are you collecting the data? So
The research question, yes, as well.
search question. All right, I mean, oh, go ahead.
Significance.
Significance. Data analysis. Those are some key research elements, right? So what I did is, I came up with some of those elements, collecting data, data analysis, hypothesis, research approach, research question, variable. And that kind of has to do with the control groups, measurements, research design, samples, anticipating problems, confidentiality. Depending on if you're working with humans, there's a huge confidentiality factor when it comes to getting patient samples or human samples. Correlation, data, descriptive, ethics. Are we being ethical? So one of the things that I noticed on Dr. Keller Ross's thing, there was 2, I'm like, oh, that IRB. So an IRB is an internal review board, and you have to have a procedure in place to make sure that it's not causing undue pain. And it has to be.
Oh, the ice bath.
Yeah. So the ice bath, I'm like, okay, so that would have had to gone through an internal review board, making sure that it's not going to cause pain that's not necessary for the study. And you have to do this with animals too, when you propose those studies. The other one was the study in Colorado where you're inducing menopause. Is that permanent? What are the effects of that? Can that be painful or detrimental to the patient? And so ethics can kind of come into play. And you can also think of ethics and like falsifying data, things like that. So I put some of those questions in there. And then one of the things, and for the sake of time, because we went over, I probably won't have you guys. As an exercise, I was thinking about organizing this. Like if you would put this into like data kind of goes into one of these, right? Correlation design or research question. You might want to have your research question up above. Right. And so like if you can organize it, because all of these elements are found within a research study, it's just a matter of kind of where some of these things come into play. And so what I did is kind of did it for you. I took all of those questions and putting it into this example. And I would say ethics goes throughout. You want to be ethical in collecting data. You want to be ethical with patient samples. You want to be ethical with your study design, research design. So I'd put that in kind of the whole thing. And same thing with the research design. And then I divided it into research approach, looking at the research approach, and we're going to talk more about that tomorrow. Reviewing the literature, research question, hypothesis, anticipated problems. You want to, when you're designing your experiment, you want to try to anticipate those problems as much as possible. And what is the purpose? Why are you doing this? And I'll talk more about that tomorrow. I'm going to use, while she was talking, I was able to take some of her comments and her research and her questions and put it into our PowerPoint for tomorrow so that we can actually use kind of a real life example of what we're looking at. In the experiment phase, you include sample, collecting data, measurements, population, variables, and then in data analysis, is it descriptive data, confidentiality, data, results, validity, correlation design, conclusion, communication. So it was fun for me, you know. Yes, I'm a nerd. I have accepted that a long time ago. But to kind of organize it, and sometimes I need those kind of visual organization tools. And I'll talk about one tool that you can use when you're pulling in all the literature. How do you organize that? How do you kind of structure that in your brain? Because right now you've got, by the end of this, you might have like 100 papers, or you might have 30 papers, but either way, you're going to have a lot. And like, how does one paper relate to the other? And so some of those concept maps can be really helpful. And I'll show an example of that tomorrow. All right.
So I do have a question real quick, sorry. The confidentiality, is that just for the subjects or of the research itself?
It can be the research itself. So,
and why would it need to be
if it hasn't been published yet, so if you're in a really competitive field, like Amanda Keller brought, or so Dr. Ross showed us some data that isn't published yet. As a scientist, I know that I cannot use that unless I talk to her about it. So their work, and sometimes at scientific talks at conferences, you will see preliminary before published data. And it's unethical to use that data, or use that data before, use that data in your own field, because you see that too when highly competitive labs are together. Sometimes somebody will talk to somebody else from in the lab and they're like, oh, that's a great idea. And then they do it. And if they can get that published beforehand, it's kind of like scooping them, which there's nothing stopping you from doing it. It's just, we want open communication from scientists. And so if we have an agreement that, you know, what you say to me, you know, unless I know it's published or it's for public consumption, I am not going to use in my personal work. Does that make sense?
Yeah, it makes a lot of sense.
All right. All right. The research process steps overview. So the first part is to develop a topic. You're going to develop a research question, develop a topic. In your case, in this situation, you're kind of being put into a topic, right? So you're going to be placed in a lab. And it's really not until you get to potentially postdoc, but more likely a full professor where you're actually directing what the topic is and what the research is. And a lot of that, I mean, makes sense because if you were to start out right away, would you know what you wanted to do? Would you be ready to pull the trigger and manage a $1 million grant to, you know, take care of everything? So this is part of that learning. And a lot of postdocs will, or graduate students, you know, they'll go on from graduate school to postdoc to a professorship or go into industry. But a lot of times what they end up doing, it was something that they worked on in undergrad that they really liked doing. Then for experimental design, you design an experiment, controls, collect data. Some of that, you know, you're going to work with your research mentor for an experimental design. There's a lot that goes into it. Then you evaluate and analyze the information. This is where statistics come in. This is where your confidence values, p-values, and evaluating your data. And then you're going to write, organize, and cite sources. You can write it in a paper outline form. If you're going to write a paper, for this program, we're going to use a poster, which is significantly less amount of writing because you're going to be presenting that. But I can work with you too if you want to write a paper. And then you're going to communicate that information. Most likely for you guys, it's going to be a poster presentation. Who knows? You know, like if you do something great in this lab and you have a great figure, you know, even if it's one figure, your name will go on that paper as being associated with that work. So you guys have potential to be part of a publication. When that might come out, I don't know. Liz was just telling me that while she was in graduate school, she was doing some work, and just in the last week, and this was a couple of years ago that she did the work, she got a notice that her figure was going to be published, and so she's going to be a published author on that. And you don't know what's going to happen in the next couple of years, and your work might be utilized with that. But we're going to use our main form is communication, is to develop a poster. We will also have a presentation at the end. All right. Let's see. Okay. So let's look at, oh, go ahead.
I was just wondering because you maybe it was Liz that mentioned it, but there was someone who had been contacted about their research poster panel kind of deal and sent off, like they flew them somewhere.
Oh yeah.
Yeah.
I think Liz knows more of the details of that. I think that was Liz.
Okay.
Yeah.
Maybe I'll ask her about it.
Yeah. From my spring cohort, when we were doing the virtual epidemiology research, I have one student that's going to go to a conference, and the other one is encouraged to. We try to get her to apply. We can't force you guys to do anything, but so I have at least one of my spring cohort students going to, I think it's Birmingham, maybe, or Baton Rouge, for a conference there. So it'll be exciting. All right, let's talk mainly about experimental design today. So in experimental design, there are different types of research. And so we'll help categorize it. Sometimes when we categorize things, you can categorize, and I always think of this in terms of anatomy and physiology. You can categorize in terms of anatomy, like structure, or you can categorize in terms of function. And so like some of these, when we look at the category, is what are we kind of looking at? So I'm gonna play that.
Let's kick off with qualitative research. This is the realm of work.
Oh, I did that again.
Words, meanings, concepts, and experiences. Imagine you're exploring a dense forest, not to count the trees, but to understand the nature of the forest itself. That's qualitative research. It dives deep into understanding how and why. You might conduct interviews, focus groups, or ethnographic studies. It's about getting beneath the surface, exploring nuances, and gaining insights that numbers alone can't provide. But what if numbers are your thing? That's where quantitative research comes in. This is all about quantifying data and generalizing results from a larger sample population. Think of it as surveying a wide landscape from a high vantage point. You're collecting numerical data through surveys, experiments, or statistical analysis. It's about finding patterns, testing theories, and drawing general conclusions. Now let's talk about mixed methods research, a powerful blend of both qualitative and quantitative research. It's like having a bird's eye view of the forest while also walking through it. This approach allows you to explore a research question from multiple angles, offering a more comprehensive understanding of the topic. But wait, there's more. We also have descriptive research, which is all about observing and describing. It's like being a naturalist, meticulously documenting what you see and experience. This method is great for providing an accurate snapshot of events or phenomena as they naturally occur. Next up is analytical research. Here, you're not just observing, you're dissecting and examining every piece of information. Think of it as a detective piecing together clues to form a coherent picture. It involves critically analyzing and interpreting existing information to uncover new insights. Then there's applied research, which is all about practical application. It's like being an engineer, using research to solve specific real-world problems. This type is often used in fields like technology, medicine, or education. We can't forget about fundamental research, also known as basic or pure research. This is driven by curiosity and a desire to expand knowledge. It's like being an explorer, charting unknown territories just for the sake of discovery. In contrast, action research focuses on solving immediate problems through a cycle of action and reflection. It's a hands-on approach, often used in fields like education, where you implement a strategy, observe the outcomes, and adjust accordingly. Lastly, let's touch on longitudinal and cross-sectional research. Longitudinal studies are like time-lapse photography, examining a subject over a long period. Cross-sectional research, on the other hand, is like a snapshot, studying a particular phenomenon at a single point in time. Every research type offers its unique benefits and challenges. For instance, while qualitative research provides depth, it may lack generalizability. Quantitative research, while statistically robust, might miss contextual nuances. That's why your choice of research type should align with your research question, objectives, and the specific requirements of your field. As you embark on your research journey, remember to consider the ethical implications of your chosen method. Whether it's ensuring the confidentiality of your interview subjects in qualitative research or considering the potential impact of your experimental design in quantitative research, ethical considerations are paramount. Also, think about the resources available to you. Do you have access to the necessary data for quantitative research? Can you engage with participants for qualitative studies? Your logistical capabilities can often influence your choice of research type. Before we wrap up, I want to ask you, our academic community, what challenges have you faced in selecting the right type of research for your projects? Share your experiences in the comments below. We're here to learn from each other. And remember, if you found this video helpful, please like, share, and subscribe.
All right. So a lot of times there's channels on YouTube. I like the Dissertation 101 because it kind of gives an overview of different types of things. Have any of you in your academic really looked at quantitative or qualitative research? Had any experience with that? I'm just trying to gauge kind of where you guys are at.
Is there an either or to it?
Sure.
Oh, I kind of just mix them together. Like you need both to get the whole picture.
Yeah, and I think that in the research that we saw before, they needed kind of both quantitative and qualitative because they needed to talk to the patients about when they were feeling these things. They needed to get kind of their observations and their signs and symptoms. And so they have to work with the patients in order to do some of that qualitative research. All right. So when we look at classification of science or research, you can have basic or applied research. Basic research is more of that pure research. You're doing it for knowledge, right? You're not looking for an application. You see that a lot in academic research. Applied tends to be more industrial engineering. You see a problem, right? And you're trying to fix that problem and you're hoping that your research will be applied at the end. What are your goals of the research? Is it exploratory? Is it descriptive? Is it explanatory? Is it normative? The approach can be quantitative or qualitative, and then you have all sorts of different methods that we can choose from. So we're going to take a look at applied versus basic research. So types of applied research.
Hey there, welcome back to Writers ER. This is the go-to channel for all aspiring doctoral and PhD students who are navigating the complex journey of dissertation and thesis research. Today, we're diving into a topic that's crucial for every researcher, understanding the different types of applied research. Just imagine being able to tailor your research approach precisely to your study, saving you time and stress. That's exactly what we'll explore today. Let's start with applied research. It's like a bridge connecting the theoretical world of knowledge with the practicalities of real-life problems. It's specifically designed to answer questions and solve issues in various fields, from healthcare to engineering and even marketing. Unlike basic research that explores theoretical concepts, applied research aims at creating real-world applications. Now let's talk about action research. Picture yourself working in a team, collaboratively solving a specific problem. That's what action research is all about. It's hands-on, dynamic, and it revolves around developing practical solutions in real time. It's common in educational settings or organizational development, where the immediate application of results is key. Next, we have evaluation research. This is your tool for assessing the effectiveness of programs or interventions. Think of it like a magnifying glass examining what works, what doesn't, and how things can be improved. It's widely used across various sectors, especially in education and social services, to refine methods and outcomes. Moving on, let's explore developmental research. This is where innovation blooms. It's all about creating new products, tools, or processes. If you're into developing new technology, designing software, or engineering new gadgets, this type of research is your playground. It's about turning concepts into tangible solutions. If you found this video helpful, don't forget to like, share,
All right. So that was applied research.
and subscribe to Writers ER for more insight.
Let's look at basic research.
Also known as basic or pure research, is a vital part of scholarly inquiry. It aims to contribute new knowledge by exploring new theories and principles. Let's start with descriptive research. Imagine you're a detective, carefully observing and describing the phenomenon around you. Descriptive research does just that. It involves collecting data that describe events and then organizing, tabulating, depicting, and describing that data. This type of research is valuable in providing answers to questions like what, who, where, and when, giving you a solid foundation for further investigation. Next, we have exploratory research. This type is like taking the first step into unexplored territory. It's like turning on a flashlight to shine a light on the unknown areas of a research topic. Exploratory research is usually used when the problem is not well defined. It involves doing a preliminary investigation to help formulate a hypothesis or research question. Think of it as a fact-finding mission in the world of academic research. Don't forget to like and subscribe for more tips on figure out which type.
There we go. All right. So that kind of gives us the difference between applied and basic research. Does anybody have any questions about the difference between the two? All right. So now let's look at classification based off of goals. So descriptive research essentially aims to provide a detailed picture of the phenomenon, a population, trends. The goal is really to just understand the situation. You might not know why something's happening or what's causing something, but you're wanting to understand more about the situation. Exploratory research is usually conducted early in a project when there's little existing knowledge. So you don't have a lot of, even after your literature review, there's not a lot of work being done. But hopefully it'll gain insights, trends, and help provide a basis for future work and future analysis. Explanatory is why you answer questions like why or how by explaining something. And normative research aims to provide more recommendations, advice, rules, designs, artifacts to improve the world. You see this kind of more, at least I see it more in a clinical setting. They talked about hypertension guidelines, moving from, it was at 140 before you considered hypertensive, and now it's down to 130. That was based off of different research. So my first example was just kind of like looking at that clinical research. All right. Now let's look at the approach. Quantitative versus qualitative or combined research. And I'm going to explain that.
When doing research, you often have to choose between quantitative and qualitative research. In this video, I'll explain the differences between the two. Hi, I'm Jessica from Scribber, here to help you achieve your academic goals. Let's start with the differences between quantitative and qualitative research. Quantitative research allows you to test hypotheses, so you can expect to see data collected with this approach will mainly be expressed in numbers and graphs. It also requires a larger sample size. These numbers are then analyzed through math and statistical analysis. On the other hand, qualitative research allows you to formulate a hypothesis. So yes, opposite to quantitative research, this approach will yield data that's expressed in words, and also require fewer respondents. The data is then analyzed by summarizing, categorizing, and interpreting. All right, now we know the differences, but when to use which? It's very simple. If your goal is to confirm or test a theory or a hypothesis, you're most likely going to opt for the quantitative approach. But if you want to understand or explore an idea, then you should go for the qualitative approach. There's also a third approach, which combines quantitative with qualitative. And this is called the mixed method. Let's see how it applies in a concrete example, shall we? Say we want to find out how satisfied students are in their studies. I'll show you how both approaches can answer this question. If I'm taking the quantitative approach, I can survey 300 students at the university and ask them questions like, on a scale from 1 to 5, how satisfied are you with your professors? With the collected data, I will run a statistical analysis and draw conclusions that might sound something like, on average, students rate their professors 4.4 out of 5. But if I want to go for a qualitative approach, then I can conduct interviews with 15 students and ask them open-ended questions such as, how satisfied are you with your studies? Or, what can be done to improve the study program? Then, I transcribe the interviews and try to find patterns or recurring themes. For example, something like students would like to have more one-on-one guidance from their professors. For the mixed method approach, you first conduct interviews with the students. Through that, you gain new insights and come up with a hypothesis. For example, you learn through interviews that students prefer individual assignments over group projects. Then you test whether this applies to a larger scale of students using survey research. It's also possible to do it the other way around. You can start out with a survey to see the bigger picture, then use interviews to understand the reason behind it. Now, I will go over data collection for both approaches in this video very briefly, but if you want to know more, just check the article in the description. To collect quantitative data, you can, for example, survey people online, in person, or over the phone, conduct experiments, or observe subjects. On the other hand, collecting qualitative data can be quite different. You can do an interview, get a focus group, do a case study, or a literature review. And that's it for this video. If you've learned something, give this video a like, and if you have any question, ask away and I will reply.
All right, any questions on quantitative or qualitative data? No? Okay. All right, let's look at some of the different methods.
What are the different types of studies out there and what do they mean? For example, an observational study versus a randomized controlled study. What are the different types of studies?
I think broadly speaking, you can break studies into three categories. One would be observational studies, and we'll bifurcate those or trifurcate those in a minute. Then you can have experimental studies, and then you can have basically summations of and or reviews of and or analyses of studies of any type. So let's kind of start at the bottom of that pyramid. And I think you actually have a figure that I don't like very much, but I know it's
say,
yeah,
that was one of your favorites.
yeah, I can't stand it. I'll tell you what I like about the figure. I like the color scheme because my boys are so obsessed with rainbows that if I show them this figure, they're going to be really happy. So let's pull up said rainbow figure.
Okay, got it.
Okay, so you can sort of see these buckets here, and again at the level of kind of talking about them, I think this makes sense. What I don't agree with the pyramid for, Bob, is that it puts a hierarchy in place that suggests a meta-analysis is better than a randomized control trial, which is not necessarily true. But let's just kind of go through what each of these things mean. So looking at the observational studies, an individual case report is, look, I think the first or second paper I ever wrote in my life when I was in medical school was an individual case report. It was a patient who had come into clinic. This was when I was at the NIH, and this was a patient with metastatic melanoma, and their calcium was sky high, dangerously high, in fact. And obviously our first assumption was that this patient had metastatic disease to their bone and that they were lysing bone and calcium was leaching into their bloodstream. Turned out that wasn't the case at all. It turned out they had something that had not been previously reported in patients with melanoma, which was they had developed this parathyroid hormone related like hormone in response to their melanoma. So this is a hormone that exists normally, but it doesn't exist in this format. And so their cancer was causing them to have more of this hormone that was causing them to raise their calcium level. It was interesting because it had never been reported before in the literature. And so I wrote this up. This was an individual case report. Is there any value in that? Sure, there's some value in that. The next time a patient with melanoma shows up to clinic and their calcium is sky high and someone goes to the literature to search for it, they'll see that report and it will hopefully save them time in getting to the diagnosis.
So your mentor and friend, Steve Rosenberg, I think of him when I think of individual case reports where I think if you listen to the podcast, he talks about this, but a lot of what motivated him early on, I think were just a couple of cases. And I think it gets back to that first question too, about the process for a study to go to an idea to design to execution, which is to have a hypothesis, you need to make an observation.
Right.
So you make an observation, you say, that's strange. And I think that's what individual case reports can represent sometimes is this is an interesting observation. It's hypothesis generating for the most part, but it might kickstart a larger trial, or it might kickstart a career. You never know.
Yeah, exactly. Now, of course, it's not going to be generalizable, right? I can't make any statement about, the frequency of this in the broader subset of patients. And obviously I can't make any comment about any intervention that may or may not change the outcome of this. So that gets us to kind of our next thing, which is like a case series or set of studies. So here you're basically doing the same sort of thing, but in plural effectively. So you wouldn't just look at one patient, you would say, well, I've now been looking back at my clinical practice and I've had, 27 patients over the last 40 years that have demonstrated this very unusual finding. And another example of this, going back to the Steve Rosenberg case, would be one could write a paper that looks at all spontaneous regressions of cancer. There's obviously been a number of them. They're infrequent. In fact, they're exceedingly rare, but there are certainly enough of them that one could write a case series. So now let's consider cohort studies. So cohort studies are larger studies, and they can be retrospective or they can be prospective. So I'll give you an example of both. So a retrospective observational cohort study would be like, let's go back and look at all the people who have used saunas for the last 10 years and look at how they're doing today relative to people who didn't use saunas over the last 10 years. So it's retrospective. We're looking backwards. It's observational. We're not doing anything, right? We're not telling these people to do this or telling those people to do that. And the hope when you do this is that you're going to see some sort of pattern. Undoubtedly, you will see a pattern. Of course, the question is, will you be able to establish causality in that pattern? Cohort studies can just as easily, although more time-consumingly, be prospective. So you could say, I want to follow people over the next 5 years, 10 years, who use saunas and compare them to a similar number of people who don't. And now, in a forward-looking fashion, we're going to be examining the other behaviors of these people and ultimately what their outcomes are. Do they have different rates of death, heart disease, cancer, Alzheimer's disease, other metrics of health that we might be interested in? Again, we're not intervening. There's not an experiment per se. We're just observing, but now we're doing it as we march forward through time. Okay. So this brings us to the kind of the next layer of this pyramid, which are the experimental studies. And again, sort of divide these into randomized versus non-randomized. And of course, this idea of randomization is going to be a very important one as we go through this. So a non-randomized trial sometimes gets referred to as an open label trial, where you take two groups of people and you give one of them a treatment and you give the other one either a placebo or a different treatment, but you don't randomize them. There's a reason that they're in that group. So you might say, we want to study the effect of a certain antibiotic on a person that comes in the ER, and we're going to take all the people that come in who look a certain way. Maybe they have a fever of a certain level or a white blood cell count of a certain level, and we're going to give them the antibiotic. And the people who come in, but they don't have those exact signs or symptoms, we're going to not give an antibiotic to, and we're going to follow them. That's kind of a lame example. You could do the same sort of thing with surgical interventions. We're going to try to ask the question, is surgery better than antibiotics for appendicitis or suspected appendicitis? But we don't randomize the people to the choice. There's some other factor that is going to determine whether or not we do that. And as you can see, that's going to have a lot of limitations because presumably there's a reason you're making that decision, and that reason will undoubtedly introduce bias. So of course, the gold standard that we always talk about is a randomized control trial where whatever question you want to study, you study it, but you attempt to take all bias out of it by randomly assigning people into the treatment groups, the 2 or more treatment groups. We'll talk about things like blinding later, because you can obviously get into more and more rigor when you do this. But before we leave the kind of experimental side, anything you want to add to that, Bob?
I would add, so non-randomized controlled trials, maybe another example. I'm trying to think of another example, which is you have patients maybe making a decision beforehand, which we'll get into selection bias, but people might want to go on a statin, let's say, and then you give them a choice, and the other ones might want to go on some other drug like ezetimibe.
Mm-hmm.
And they're basically selecting themselves into 2 groups, but you could compare those 2 groups and see how they do, but you haven't It hasn't been randomized. There's a lot of bias that can go into that. There could be a lot of reasons why one group is selecting a particular treatment over the other. So that's why I think when we get to randomized trials, that it shows the power of randomization.
Yeah, exactly. But we don't need to go back to the figure, but people might recall that at the top of that pyramid was, systemic reviews and meta-analyses. Let's just talk about meta-analyses since they are probably the most powerful. So this is a statistical technique where you can combine data from multiple studies that are attempting to look at the same question, basically. So each study gets a relative weighting, and the weighting of a study is sort of a function of its precision. It depends a little bit on sample size, other events in the study. Larger studies, which have smaller standard errors, are given more weight than smaller studies with larger standard errors, for example. A very common way that these, you'll know you're looking at a meta-analysis. We should have had a figure for this, but I'll describe it the best I can. They usually have a figure somewhere in there that will show kind of across rows all of the studies. So let's say there's 10 studies included in the meta-analysis. And then they'll have the hazard ratios for each of the studies. So they'll represent them usually as little triangles. So the triangle will represent the 95% confidence interval of what the hazard ratio is, which we'll talk about a hazard ratio, but it's basically a marker of the risk. And you'll see all 10 studies, and then they'll show you the final summation of them at the bottom, which of course you wouldn't be able to deduce looking at the figure, but it takes into account that mathematical weighting. So on the surface, meta-analyses seem really, really great, right? Because if one randomized trial is good, 10 must be better. But again, I know I've said this before, probably 3 or 4 times over the past few years on the podcast. But as James Yang, one of the smartest people I ever met when I was both a student and fellow at NCI, once said during a journal club about a meta-analysis that was being presented, he said something to the effect of 1,000 sow's ears makes not a pearl necklace. And that's just an eloquent way to say that garbage in, garbage out, right? So if you do a meta-analysis of a bunch of garbage studies, you get a garbage meta-analysis. So it can't clean garbage. It simply can aggregate it. So a meta-analysis of great randomized controlled trials will produce a great meta-analysis.
All right. Any questions on that? I thought he did a really nice job of kind of going over some of the different types of analysis, the strengths, as he went through on reporting, and how in each case, you're trying to eliminate bias, you're trying to eliminate selection bias, you're trying to make sure that what you're testing for is what the answer is going to show you, right? There are different types. This is just a different view of kind of they had the pyramid graph. This one shows a little bit different one. I mean, the anecdotal expert opinions, that might be, kind of what that first example that he looked at. Then you go into the experimental, where you have the animal and cell studies, the case reports, case series, case control studies, cohort studies, randomized trials, systematic review. So it's similar to what he was talking about there. Sorry, a package just got delivered to my door. So the dogs are. Okay. That UPS man, I don't know. There's something really up with him. All right. Questions about the different types of scientific evidence, scientific studies? No, it's okay. All right. All right. All right, so now let's look at how you'd evaluate and analyze information. So different types of statistics. Some of this goes into one of the things I wanted to make sure that I said in this file is data literacy. You guys are going to be collecting lots and lots of data. I can't stress enough of making sure that you have a file system that makes it easy. And I know as time goes on, it's easier to get away from that file system. Like I still have stuff on my desktop that should be in a folder. You know, because I wanted it right access at that time, but you know, now I have to look for it and do the search function. So organizing how you do your article. So creating a folder, you know, for the pathways research, then creating 3 subfolders, one for your professional development, one for your research, one for your lab skills. And then you can put in, you know, your articles. Even naming articles, you should have a system. First author year usually works for me. Sometimes you have the same name of the first author and the same year, and then I have like A, B, or like a little note by it. You know, however you want to organize it, that it keeps, you know, so that you're able to keep track of or find it easily. You know, even with our folder that we're sharing on Google, I wanted to make sure that I had day 1 as a separate folder from everything else so that you guys are not looking through all of that. So I can't stress enough, just whatever your system is, right? You can create your own system. Whatever your system is, just be aware of that and try to start right away. All right. Write, organize, communication. Science writing is different than creative writing, right? Or what you'd have in like an English essay, or what you'd write in an email, or what you'd write for anything else. Science writing is different. It seems to be, it feels very dry and matter of fact. You typically don't use I statements. There's no feeling associated with it. It's just very cut and dry. So let's take a look at writing a scientific article.
Well, okay, so the first thing I tell all my students and postdocs and so on is you want to think about writing a paper in terms of telling a story. Okay, so you have to have a vision as to what that story is, because that's the way that you're going to make the writing process the most efficient. So it's before you ever write anything down, it's mostly just at the level of let's talk about what this paper might be. And it always ends up being, what's the story you want to tell? I am often see papers that are submitted. And of course, as the editor, I'm looking at the papers and I'm saying, okay, what's their story? And unfortunately, sometimes I get papers where there's no story. Okay, it's just simply, here's some results that we generated and just take it or leave it. And it's like, okay, this is no story. Okay, so that's a problem.
I think it's important that people read a lot of the literature and find papers that really inspired them. And if you watch some of the masters of chemistry tell their stories in the literature, I think that's really the best way to learn, to read, think about how they did it, and then think about how you could potentially map your story onto theirs.
When you meander and start trying to write a paper and then figure out the significance of it as you go along, I think it often leads to a very difficult to tell story and a poorly told story. So I'm a big proponent of, before we do anything, let's ask what it is that we can conclude, what we've taught the world.
Sometimes a story and the important results can get buried in a paper. And so I think it's really critical to think about what your most compelling results are, what your key advances are, and to be absolutely certain that you build the introduction and build the story of your paper around conveying those results. If those get lost in mounds and mounds of data and data interpretation, you're going to have a much less likely chance of garnering excitement from the reviewers for your paper.
So I spend a lot of time just trying to think about how to tell the story. And sometimes, especially with very complicated research where there's a lot of stuff in the details, that can be quite difficult. to get the story across. You know, my students come to me with a first draft, and if it's a paper, and the first question I ask them is, what is the story? Right? What is it you want me to get? So once I get that, for me, then I can understand how the paper gets put together. But until I get that, I think it can be kind of difficult.
All right. So, I mean, it really is about the story, and you want to know why. Why am I reading this? Why is this important? I find that when I lecture in class, and I especially see the glazed over, I will stop and go, okay, why are we doing this? Let's recheck in. Because I get the glazed look a lot. I'm a science teacher. It happens a lot. So, you know, it's like, let's check in. Why do you want to know this? Why is this going to help you either later in this class or later in your life or in just kind of the world in general? And usually that pulls them back in a little bit. Not always, but it sometimes do. So I went in and looked at, I'm actually better at writing science papers and scientific writing than I am creative writing. I struggled a lot in college and undergrad writing any type of creative essay. Why do I have to add all these descriptors about how I feel and, you know, all of this kind of extra stuff? It just felt like extra stuff to me. So English was a struggle. Those classes where you had to write papers were tough on me. But I like scientific writing. And so I found some like just kind of tips that you can use that are concrete. When you're writing your title, you want to keep it concise yet informative as possible. Usually, typically it's about 10 to 20 words. An example, you know, rather than pH regulation in coral, you want better title would be effects of light and darkness on pH regulation in 3 coral reef species exposed to seawater edification or acidification, right? That tells you exactly what that article is about. The abstract, it should mirror the full paper, right? It should include parts of the introduction, parts of the aims, parts of the methods, parts of the results, parts of the discussion. You want to start with that broad introductory, which would be kind of part of the introduction too. Like, why are you doing this? Why is this research important? When you get to the introduction, right? You know, you're providing background information about why you did the research, but also like, where's the gap? Like, how is this new compared to, how does this provide me any new or better information than I already have? So sometimes there's a gap in the literature. And I think Dr. Ross was talking about that earlier of like, the differences between men and women and cardiovascular disease and what does that look like? And so she's looking at some of those knowledge gaps. All right, figures and tables. Use declarative statements or titles that summarize the result and major finding that you're presenting in the figure. The captions should be standalone. I should be able to look at your figure and know what you did in that figure without knowing anything else about the paper. In the discussion, remember the triangle rule, start narrow, summarize your main finding in the first paragraph, then zoom out, putting the findings in the context of previous studies. So go back to that, why were you doing this? And now you're talking more about that impact that your study will have. Use the active voice. So instead of the expression of X was determined by, we determine the expression of X. General writing tips, keep the subject and the verbs of the sentence close together. And I have kind of more of those general writing tips on the next slide. There we go. The 7 principles of writing. You got to place the new information you want in the reader, want the reader to emphasize in the stress position at the end of the sentence. Save the best for last. Place old information, material you already started, in the topic position to link the reader back. 4, follow the subject as soon as possible with its verb. Let's see. I'm kind of jumping all over. Let's go over to 2 here. Place the person or thing whose story a sentence is telling it at the beginning of the sentence in the topic position. Provide context for your reader before asking that reader to consider anything new. Articulate the action of every clause in a sentence in its verb, and in general ensure that the emphasis of the substance coincides with the expectations for emphasis raised by the structure. These were just practical tips. You'll have to decide if you're, it's been a while since I've taken a grammar class, so some of the terminology is a little bit off for me. I wouldn't exactly say it that way, but that's okay. All right. Any questions on kind of what we went over today? No? Okay. All right. I didn't put yesterday's information into the Google Drive. I will. There is a channel that I have for YouTube. I can send you guys the link and it'll have everything that I record for this program on that channel. I will also try to get other people to send me the recording so I can publish to the same channel. All right. Well, let's look at tomorrow.
How do you deal with so many tabs?
I don't know. I mean, I know what a lot of these are because this is PubMed. And this is Mid-State, my Google Drive. I mean, so I know what a lot of them are, but yeah. It's a lot. I've been told it's a lot. And I did previously melt my hard drive. So like in my computer, it got melted. It was having problems. I sent it to my IT friend and he showed me a picture of it after he took it out and it was like all melted. Yeah. So
that's crazy.
Yeah, so don't do what I do. All right. Dr. Huang is next, who's also working with Peter Kang. Let's see if I can find. Yeah, I will see if I can find some articles to work with Peter's group. There is another. Yeah. All right. I will send you a link to articles from those groups so that you guys can, keep up to date and read. In general, read 3 articles for tomorrow. Make sure you're ready to go and prepared to ask questions. You guys did great today. Is there anything else I can do for you today? No? All right, you guys are free to go.
Thank
All
you.
right, thanks.
Thank you very much.
Thank you.